MIGS has undoubtedly changed the way glaucoma is managed in the clinic. The safety profile associated with a category of stents, surgeries, and procedures makes them a suitable option for use early in the disease continuum, offering the potential to help patients gain greater control of their intraocular pressure while reducing their dependence on medications. The good news for patients is that the pace of innovation in MIGS continues to accelerate, including new devices and surgeries coming to market, as well as subtle changes to how MIGS is used in real-world practice. The growing popularity of standalone MIGS surgery uncoupled from cataract surgery, is one such development that is poised to alter glaucoma management for the better. While the benefits of MIGS are well known, there's always a question of practicality when it comes to offering a new service in the clinic. Is the changeover to standalone MIGS difficult? Does it interfere with clinical or OR workflow? Will it impact efficiency? How can surgeons assure success? In an effort to gain real-world perspective on what it takes to implement standalone MIGS into practice and what impact, if any, it has on clinical operations, Sight Sciences engaged with early adopters to find out why they made the change and what tips they can offer to peers thinking about adopting standalone MIGS.
Hi there, my name is Parekh, and I'm an anterior segment eye surgeon here in northern New Jersey. I practice at Eye Care Consultants of New Jersey. And I would love to invite you here in our practice to talk about how we've incorporated standalone MIGS.
The first question many surgeons might ask is, why?
We've been doing MIGS for a lot of years, usually during the time of cataract surgery. As we got very comfortable with this around the time of cataract surgery, we realized that there's still a lot of patients that could benefit from a MIGS procedure. So for that patient who's much younger, who doesn't have a cataract, or that patient who's had cataract surgery years ago that now needs another intervention, we find ourselves really in an interventional glaucoma space where it's important to look at that unmet need and offer really cool, efficient technology in taking care of these patients. For us, it was an easy transition to go to standalone canaloplasty with trabeculotomy, otherwise known as the OMNI system. And all we had to do is really look at the unmet need in our clinics. And that unmet need was a younger patient who did not have cataract, had glaucoma, could not handle polypharmacy, or the drops weren't working well enough, or may have had SLT, or may have had an intracameral biodegradable implant and now needed something else as a gateway. And then the other category are the patients that have had cataract surgery or cataract surgery with a MIGS and now several years out, a couple years out, needed an intervention.
Once the surgeon has made the decision to start offering standalone MIGS, the conversation turns to what steps are necessary to fully integrate it in the clinic and operating room.
There is not one surgeon that's successful without the team behind him or her. And it's easy for me to tell the patient, this is what I want to do. In this case, a standalone MIGS. But then to take it to my coordinator, my planner, our manager, and to get that booked efficiently at the operating room, at the hospital or the surgery center has been incredibly important. So for us, that battery of communication has been so important to make sure patients get what they need.
The first time whenever you introduce something is kind of challenging. People have to understand the benefits and why are we doing it. Dr. J was able to pull through all kind of conversation in a very understanding way between like him and us and with my staff. So they had the understanding of what we are doing and why are we doing. When we put the patient perspective into it, that how reliable it will be for those patients and the patients, the outcomes will be very much benefiting to the patients. My staff was able to kind of get on the board and we were able to work out the process.
Part of the process that Dr. Parekh's practice implemented is block scheduling, or dedicating a certain part of the OR schedule just to standalone cases.
Here in the operating room, compared to cataract surgery or cataract with MIGS, when you're doing a standalone MIGS, it's really a bit different. And the differential is a couple things. Number one, the throughput time, the efficiency, getting people in and out of the operating room in an efficient, safe manner. So that efficiency, we've tuned everyone in the operating room, outside the operating room, the pre-op area, the post-op area. That whole journey, which is captured and has become very efficient. So for our standalone cases, we actually do block scheduling. And what that means is we do all of our standalone MIGS consecutively for the first couple of cases in the morning. Sometimes that may occupy the whole morning. Sometimes that may occupy the first 3 or 4 cases. Then we'll do our cataract MIGS, then we'll do our cataract only. And what that does, it really makes everyone efficient and targeted to that portion of the morning. And by doing that, it's got an amazing buy-in from all the stakeholders, including anesthesia, our operating room manager, our technicians, the patients, and the families.
Standalone MIGS has been a very exciting part of our anterior segment surgery armamentarya, especially this year. And I will say that when we're booking our patients, an already busy schedule that's filled with, in my case, cataract surgery with MIGS, and maybe some corneal procedures, we tend to book these patients consecutively, especially if there's a couple or several. That way the anesthesiologist, the nurses, the scrub techs all know that these patients are being treated in a very efficient fashion with lesser anesthesia, lesser furniture in the operating room, and really just focusing on the device and a little bit of viscoelastic and what it takes to do the procedure within a couple of minutes. And that's truly made that turnaround time and that block of time very efficient when we're doing several cases. There are times that we are adding on patients for standalone MIGS, and we may not have the luxury of block time just for standalone MIGS. So we have 1 or 2 or 2 or 3. We'll still book them consecutively, and usually to dovetail and piggyback other cataracts with MIGS. That way, the anesthesiologist and the OR team know that we're doing a MIGS device, in this case ergo, for our canaloplasties, and that it's going to require lesser anesthesia, lesser instrumentation, and obviously we can book them in a much smaller period of time. And that's worked very, very well. In my OR, standalone MIGS is its own entity, and our nurses and managers at all 3 centers that I operate out of all know what it's going to take for booking these patients, either through block time or non-block time.
The benefits for efficiency described by Dr. Parekh and other surgeons is easily appreciated by other members of the OR team. Altogether, standalone MIGS requires less instrumentation and setup compared to cases that are combined with cataract surgery, meaning that cases are typically completed in less time and that room turnover is simplified.
When doing standalone MIGS in comparison with the cataract MIGS, I feel like the standalone MIGS is more simpler. So I eliminate IAs, I eliminate the phaco upsetting, I only use syringes, just BSS, and incisionals, and the gels, which is the viscoelastics. As my role in the OR, I feel like the benefits are to be more efficient, less anesthesia, less instrumentation, and a more simplistic way. I would feel like the turnovers are very quick, and I feel like this will benefit the whole team.
For surgeons like Jay Parekh, the implementation of standalone MIGS has not been difficult, and in fact, it helped him and his whole team realize improved efficiency and patient flow through the OR. Overall, the process has been seamless in Dr. Parekh's practice, and he says the challenge of finding appropriate candidates has simply been a matter of adopting a mindset of finding the best option for the individual patient, something that ophthalmic surgeons are already doing on a daily basis.
As surgeons, we always think about how we could have done things better. My only regret is I wish I would have offered standalone OMNI years ago, because we were doing it quite a bit during the time of cataract surgery. I would offer advice to all of my colleagues in the community, both ophthalmologists and optometrists, that these patients are in your waiting room. These patients have already had cataract surgery years ago. These patients have ocular surface issues and glaucoma. These patients have polypharmacy. Wouldn't it be cool to take these patients, that unmet need, glaucoma is a lifelong disease, and apply an intervention like standalone MIGS, helping take care of them, their journey, and helping reduce that pressure? That's the mindset we've incorporated here now for the last 1 year, and I think it's pretty easy for all of you in the community to think of it the same way.